recent landmark trial in cardiology which was presented last year in Lancet Journal. What is prevent in this prevent trial? It is prevention of acute coronary syndrome or acute cardiac event in the suspected patients in which coronary stenting or intervention is not indicated as per the past protocols. So coming to the hypothetical case or case from the case series of this trial, they have a 57 years old female with a typical chest pain and coronary angiography shown here. Here you can see the intermediate coronary lesion in proximal LAD. It is around 50-60% lesion. According to guideline, intermediate coronary lesions.
Anatomical.
Anatomical. Yes, anatomical. And we have to confirm the lesion severity with FFR. And in this case, FFR was 0.85. As per the guidelines, the lesion should be kept on optical medical management. They have
chest pain was cardiac or non-cardiac?
Cardiac pain, sir.
ECG था, enzyme था, किसकी वजह से cardiac है?
They have not mentioned everything. They have just mentioned angiography and.
But what was the troponin? Was the troponin
No, not a stable patient. Stable angina patient.
Stable.
If it is cardiac, then why it is atypical?
To load cardiac cause they have done angiography, sir. And angiography is FFR negative, so less likely cardiac chest pain they have looked.
तो ये जर्नल में आया हुआ केस?
हाँ, journal. This is a case from the journal only. Journal case series. And details were not available apart from angiography and some morphology.
Usually atypical case when होगा troponin negative होगा तो you will go for other investigation before patient undergoes angiography.
Yes, definitely. Sir.
Usually such thing never happens.
Yes, we have to do TMT and coronary and CT angiography and everything. But after angiography, we are discussing about the case. And ideally, in this case, stenting is not indicated. They also done the plaque morphology investigation in this patient. Here, FFR is 0.85, which is not HB. But the morphology of plaque is IBS MLA was 2.76 millimeters square. Plaque burden was 73%. Near infrared spectroscopy LCBI was 571 and TCFA was positive, thin cap fibrosis. Means this lesion was vulnerable plaque. So whatever the plaque morphology, according to previous guidelines, we have to depend on FFR, which is functional parameter, and we will have to continue medical management.
So what percentage of diameter is obstructed with this plaque?
Yes, sir, this is plaque burden is
73.
And according to quantitative coronary angiography, sir, it is 60%, 50 to 60% lesion. More than 70% is indication of clear cut stenting. There is a gray zone bit of 50 to 70% is intermediate lesion, for which we have to investigate thoroughly, sir.
So previous parameters were with the help of IVUS or OCT or both. Previous slide में जो आपने पैरामीटर लिखे हैं.
This parameter.
हाँ, ये किस
First is IVUS, second is plaque burden is calculated by IVUS only. LCPI is the from near infrared spectroscopy, sir. This is a
near infrared spectroscopy. Okay.
And thin cap fibroadenoma ideally calculated by OCT, but it can also be calculated with IVUS.
MLA, what is MLA?
Means luminal area, sir. Area of the plaque, sir. Okay, sir. So there were various.
Plaque का एरिया था कि आर्टरी का एरिया था? Luminal area plaque
Plaque is artery का.
Artery का
lumen area of the
disease lumen.
Disease lumen area. MLS. So various studies have been conducted for the intermediate lesions. Here which are two studies I want to mention. First is stable trial, effect of statin treatment on modifying plaque composition. This trial was conducted with the same investigator in the prevent trial, and they stated that rosuvastatin induced necrotic core and plaque volume, and rosuvastatin reduced the necrotic core and plaque volume, and also decreased the thin cap fibroadenoma rate. मतलब we stabilize the plaque, statin stabilize the plaque. So we have to continue the study.
What time period?
This 1 month, sir. We have detailed. Yes.
1 month?
1 year, sir. 1 year.
1 year.
यार तुम नक्की कर.
Just I have 4 line. I have not mentioned detail of this trial, but this is the abstract of this trial. They have mentioned that during 1 year of follow, necrotic core was reduced, sir. Here in result you can see that.
Necrotic core reduced. What happened?
Necrotic, because this is the indicator of vulnerability of plaque, sir. And
what happened to the fibrous scale?
thin cap fiber reduction of decreased the thin cap fibroathoma rate, sir. They have mentioned that also.
ये पेपर मुझे शेयर करना ना?
Yes, sir.
आपके पास है ना?
There is no difference between high intensity and low intensity. That is what
No,
I
they have used the moderate to high intensity studies,
Moderate
not
to
low
high.
intensity studies.
40 milligram बचेगा.
हाँ, moderate to high.
40 milligram versus 10 milligram.
Yes, 10 milligram is low intensity, 40 is high intensity studies. I mentioned for that previous reference only, sir. Our trial is different opinion.
ना तो ये ट्रायल भी साला इंटरेस्टिंग है मेडिकल पॉइंट ऑफ व्यू से तो.
Yes, sir. Because of that, they have continued medical management in the past patient.
तो इसमें 10 मिलीग्राम में नहीं इतना प्रिवेंशन आया, 40 में नहीं आया.
So in vulnerable plaque patient, we have to continue moderate to high dose statin with ezetimibe or other lipid modifying agents.
मॉडरेट भी चलता है या ओनली हाई इंटेंसिटी होता है?
Moderate to high.
मॉडरेट टू हाई है.
Yes.
ये कौन से ईयर का आया है ट्रायल?
इस देखना पड़ेगा सर. एक 2017 का आया है. 2017.
So I guess अभी
before prevent trial, they have conducted this trial.
Yeah, but so अभी current guideline में तो only high intensity.
Zimmerman.
Yes.
Zimmerman.
And second trial was the different trial, which says that intermediate coronary lesion with FFR negative, they should be go ahead with optical medical management. 2 trials supporting the OMT for previous patient, so they continued optical medical management of that patient. What the result of this patient we will discuss after the prevent trials.
ना ये ट्रायल का पहले डिस्कस करो ना.
कौन सा सर?
डिफर वाले का डिटेल क्या है? रिजल्ट क्या है?
They have the deferral of PCI of functionally non-significant stenosis is associated with favorable long-term follow-up without signs of late catch-up phenomenon, means without late reverse progression in deferred trial. Means FFR negative lesions, we can continue medical management in that lesions. So according to this trial,
तो इसमें तो 15 साल का तो फॉलोअप है, राइट?
yes sir.
तो ये चालू कब हुआ था और इसमें कौन सी मोडालिटी हुई?
This trial was published in 2015, sir, and started along with 2001.
So this trial must not have used the IVAS and OCT in their initial this thing, right?
They have not mentioned, sir.
अगर 15 साल का फॉलोअप है मतलब 2000 में चालू हुआ होगा.
The methods were in 325 patients scheduled for PCI for intermediate stenosis. FFR was measured just before planned intervention. If FFR was more than 0.75, patients were randomly assigned to different group or perform angiography. FFR was less than 0.75. They have mentioned.
So that is only and only FFR.
Yes, only FFR.
There is no
nothing.
terminology of vulnerable plaques here.
Nothing.
This is a different thing again.
Yes, it's a different trial for FFR guided
You can
angioplasty.
be having calcified nodules or calcified plaque with insignificant FFR. तो उसमें ये ट्रायल में तो वो वाले भी आ गए ना.
They might have been excluded, so they have to go detail.
अगर आपके पास आपने OCT नहीं किया, IVAS नहीं किया, तो FFR insignificant लीजन है, तो थीन वाला है कि calcified वाला वो आप कैसे पता करोगे?
That's why the prevent trial was conducted.
तो इसमें वो नहीं था.
हाँ. This trial only evaluated the efficiency of FFR in intermediate lesions.
Okay. तो वो दोनों को कंपेयर करने का वैसे भी कोई मतलब नहीं बनता.
But in general guidelines, मतलब in general practice,
ऐसे जनरल नहीं कर सकते भाई.
Yes. Okay, sir. Coming to the prevent trial, sir. Prevent trial is preventive pulmonary versus optical medical therapy alone for the treatment of vulnerable atherosclerosis plaque, that is prevent in a multi-center open label randomized control trial. This trial was supported by investigator, initiated grant from Cardiovascular Research Foundation, Abbott, Eon Corp, Philips Infrared and Info Company. The funder did not participate in trial design, data analysis management, and the participating investigators were from 15 different sites in South Korea, Japan, Taiwan, and Israel.
There was no patient from United States.
No, sir. This trial mainly from South Korea and associated countries.
In Southeast Asia and New Zealand.
Yes, sir. Because the main investigator, yes, Park, is the main from South Korea.
The trial kind of Asia Pacific.
So coming to introduction, intrapulmonary imaging defined vulnerable plaque has more tendency to increase major adverse cardiac events. Optical medical therapy is standard approach to stabilize plaque vulnerability. The safety and effectiveness of the focal preventive percutaneous coronary intervention of non-flow limiting vulnerable plaque are unknown. There were no previous trials showing vulnerable plaque PCI outcomes. So this trial was conducted to assess whether the focal preventive PCI of non-flow limiting imaging defined vulnerable plaque to improve clinical outcomes as compared to OMT. So this was a trial design. Initially 5,627 patients enrolled with intermediate stenosis, so the diameter stenosis is more than 50%. Out of that, 2,065 patients were excluded right because they have FFR less than 0.8, and among from negative FFR, which patients have more than 0.8 FFR of 3,562 patients, 1954 patients not meeting criteria of vulnerable plaque. So coming to the final population study, total 1,608 patients were randomly assigned, out of which 803 patients were assigned to preventive PCI and the rest of patients assigned with OMT after randomization. This was the trial design. So out of this patient, 780 patients from OMT group completed 2-year follow and 766 patients completed 2-year follow from OMT alone, but 803 number was considered for statistical analysis as number needed to treat in this trial. The major inclusion and exclusion criteria of this trial: first is age more than 80, second is patient with angiographic significant stenosis more than 50% with negative FFR 0.8% and meeting two of the following criteria. These criteria is from intravascular intrapulmonary imaging, which shows MLA less than 4 millimeter square, plaque burden more than 70, thin cap fibroadenoma detected by RFIS or OCT, and large lipid-rich plaque on NIRS. These four criteria they have to diagnose the vulnerable plaque.
આપણા કેસમાં બે પહેલા ઉપર ક્રાઇટેરિયા મેં 1 and 2.
हाँ sir, our case was that case was the vulnerable plaque only, but they kept medical management. What they wanted to evaluate that only, sir. In vulnerable plaque, medical therapy, how much it is effective.
Which patient was subjected to IVUS and OCT?
Every patient, sir. Every patient in this trial.
With IVUS and OCT.
I was OCT and NIRS, all three investigations. Eligible patients for PCI was done with absorbed BVS trial or EES, everolimus eluting stent. Reference vessel diameter was 2.75 to 4 mm, lesion length less than 40 mm. These were inclusion criteria. Exclusion criteria is a patient who preferred treatment is CAB patient is excluded. Previously treated lesions, bypass graft lesions, patient with 3 or more target lesions or 2 or more target lesions in the same coronary artery, heavily calcified or angulated lesion, bifurcation lesion, and contraindication or planned discontinuation of antiplatelet. These patients are excluded in this trial. So what was the procedure? During initial recruitment rate of the trial, PCI was performed with BVS, the biovascular scaffolds. Following withdrawal of BVS, cobalt chromium everolimus eluting metallic stent were used for default PCI device. Intravascular imaging is used in all target lesion. Patient received dual antiplatelet therapy for at least 6 months to 12 months after PCI according to clinical presentation. Clinical follow-up was done at 1, 6, 12 and 24 months and every yearly thereafter. Follow-up continued annually in all the enrolled patients until the last enrolled patient reached 2 years of randomization. So what was the procedure done? First they have taken the patients with diameter stenosis around intermediate coronary lesion with FFR negative. They have assessed the plaque morphology with IVUS and OCT, and they have done optical medical therapy versus the stenting of this patient, randomized. So the study endpoints, primary endpoint was target vessel failure, the composite of death from cardiac cause, target vessel myocardial infarction, ischemia driven target vessel revascularization or hospitalization for unstable or progressive angina at the 2 years of randomization. And secondary endpoint was the individual of these endpoints with procedural safety outcomes, stroke bleeding events, and number of anti-anginal medication used at each outcomes. So, what was the baseline characteristics of this patient? The most important baseline characteristics of this vulnerable plaque patient was dyslipidemia. Most of the patient had dyslipidemia in both of the group, around 88 and 90% of the patient had dyslipidemia. And clinical presentation, most of the presentation clinical presentation of the patient was stable or silent angina, which was 83% and 84%. Here I wanted to highlight the ST elevation in my patient incidence of patient number was very less, 1% in both of the group, because most of the ST elevation in my patient have some plaque morphology like plaque rupture, plaque erosion, which was indication of right upfront stenting in this patient. So they have already excluded this. Coming to the anatomical characteristics, the main imaging modality which tells us about the vulnerable plaque was the IVUS guided MLA and plaque burden more than 70%. There were 97% of the patients from both groups which were characterized as vulnerable plaque by these two criteria only, and some of the patients 28% and 7% needed thin cap fibroid atheroma defined by velocity and near infrared spectroscopy. So generally we can say that the first two are main criteria for vulnerable plaque detection. And second things are main target lesions for most of the lesions were in LAD, and diameter stenosis, most of the patients have diameter stenosis around 56.6 in preventive PC and 52.6. Like that, they are intermediate coronal lesions only. So core lab imaging analysis, the most frequent finding was the mean lesion area less than 4 millimeters square, which I will previously. So procedural characteristics, the patient had the DES implantation. There are 58% of the OMT patient, 67% of the patient with 67% patient with preventive PCI has DES implantation, and 33% of the patient had BVS implantation. The idea is they initially started with BVS implantation, later on BVS were discontinued and they started doing DES implantation in their patients. So individual component.
Why that was done?
Sorry, sir.
Why that was done?
Why, sir?
Initially that stand and then later on that stand.
Because the trial was started in 2015, sir. At that 2015, BVS was emerging, and everyone saying that BVS is better for vulnerable plaque in intermediate lesion. After that, when result of APSO trial came, they showed don't any significant difference among DES and BVS. So BVS, at present BVS were discontinued. So coming to the endpoints of the trial, sir. The primary composite endpoint of this trial. Here we can say in the preventive PCI group was the primary composite endpoints at the end of 2 years was only 0.4%, and in OMT group is 3.4%, which is very significantly decreased, statistically significantly decreased the primary endpoint in preventive PCI groups. And same the finding observed in other individual endpoints, that is death from cardiac cause, target vessel myocardial infarction, ischemia-driven target vessel vascularization, and hospitalization for unstable or progressive angina. All these individual endpoints were less in preventive PCI groups. And the same with secondary endpoints, death from any cause, non-target vessel myocardial infarction, and non-target vessel revascularization. Other secondary endpoints, definitive state thrombosis, definitive state of scapula thrombosis. This was state thrombosis. This was nearly equal in both group, preventive PCI and OMT. And other events are stroke events were nearly equal, and bleeding events were nearly equal in both the groups. So coming to the subgroup analysis at the end of.
Go to previous practice, stent thrombosis.
Yes,
in OMT.
sir, because the 12 patients from OMT group were put on the stents because of the events. Group crude analysis of subgroup analysis of this. This slide just shows the preventive PCI group is better than OMT group according to hazard ratios. In both at the end of 2-year follow-up and at the end of 7-year follow-up only. Ideally, outcome was calculated at the end of 2-year follow-up, but they have continued the study till 7 years of follow-up, and the same results were continued. So here we can see the primary composite outcome in target vessel failure at the end of 2-year follow-up. Here we can see the preventive PCI 0.4% and OMT is 3.4%, which is very statistically significant field values. This same primary composite outcome, they followed patient till 7 years follow, and the same outcome they observed. So that primary preventive PCI was better than OMT at the end of 7-year follow also. So coming to the individual, as they initiated biovascular scaffold and later on they use the EES. When they use drug-eluting stent, the cumulative incidence of primary composite outcome was far more less than BBS, because BBS, inclusion of BBS might cause the more number of adverse events in this patient. If the same trial continued in DS group, the result might have been more promising. So these are all the composite outcomes which I have already mentioned. So summary of these findings: the PREVENT trial is the first large-scale randomized control study comparing preventive PCI plus OMT versus OMT alone in the treatment of non-flow limiting imaging defined vulnerable class. In PREVENT trial, preventive PCI reduce the composite risk of death from cardiac causes, target vessel MI, ischemia-driven TBI, hospitalization for unstable or progressive angina at the end of 2 years. Preventive PCI also reduce the composite patient-oriented outcome of risk of all-cause death, any MI and repeat hospitalization. This benefit was sustained throughout the 7 years follow-up period. To conclude, in PREVENT trial, preventive PCI plus OMT resulted in the lower incidence of major adverse cardiac event as compared to OMT alone patients. The key finding might provide novel insight on the role of preventive PCI on non-flow limiting high-risk non-labor plaque in the future. So, what was the study limitation? This study was open label, introducing the risk of placebo effects and ascertainment bias. The observed rate of primary outcomes were substantially lower than expected in both groups. The selection of imaging modality to assess the plaque vulnerability was left to operator discretion. 9% of preventive PCI group and 1% of OMT groups alone were crossroad to each other. The study did not collect data to examine cost effectiveness of preventive PCI strategy, and DAPT was greater in preventive PCI groups. So that may be the bias. Oh, so coming to
The point here is that if any patient of atypical case or typical case when comes, you go for angiogram. And I was in OCT study. Instead of doing FFR, even if you do or do not do FFR, OCT or IVAS is going to give you significant, non-significant as well as plaque morphology, vulnerable, non-vulnerable things, fibroma. So here, so my point is, FFR is not it.
But sir, initially what was protocol, sir?
What I understood.
Yes.
Here, flow limiting value, you leave it aside. Any patient or case when comes, go for angiography and go for IVAS or OCT.
Sir, what if plaque is plaque is stable but FFR is negative, FFR is positive, sir? We have to do plastic.
All these things comes only if FFR is more than 0.8.
If FFR is less than
negative, then only
although plaque, whatever the plaque morphology, if FFR comes down to 0.75, we have to state, sir, whatever the plaque morphology.
Which modality you take FFR?
Which modality, sir?
With the help of IVAS or OCT or what?
No, FFR is pressure catheter, sir.
It's a pressure catheter.
Pressure
right?
catheter.
And that catheter costing,
Costing is around, sir, 1.28 lakhs, sir. Around.
right? So what is saying is, if you can avoid that catheter, suppose if you check angio and a plaque comes in a gray zone, say 50 to 70%.
Yes, sir.
So you are almost 99.99% putting clinical picture, enzyme, ECG and everything into it. You are sure that this is not acute coronary.
Yes, sir. Yes, sir.
right? Direct go for OCD IVAS.
If
Why to use a catheter of 1.8 lakh just to see FFR?
Yes, sir, because sir, what if sir plaque is stable and FFR is negative, sir?
That is what you want to see with IVAS and OCD.
Yes.
FFR is not going to tell you whether plaque is stable or not.
Yes.
What is going to tell you?
OCD and IVAS will give more data regarding your, the length of the lesion,
Yes, sir, definitely,
thick, what is the plaque load, everything can be given by.
Yes, sir, definitely, sir.
So, sir is saying that FFR can be replaced with your clinical judgment.
Yes, sir. Clinical
Right?
judgment.
But
can
IVAS and
be
OCD you must perform if
Yes.
such type of patient comes.
Yes, sir.
60%, 55%, 70%. Yeah, where you are sure that this is not a thing which is going to cause an acute obstruction, you
Yes.
go for IVAS OCD.
But,
Or if you have
For functional
near
assessment
vision
of physiology.
infrared spectroscopy, you should take it.
but sir, for functional or physiological assessment, how we can do with IRS?
Matlab, what are the chances if a 70% obstruction can have FFR of less than 0.8?
Yes, sir. There are quite normal chances, good chances, sir. Because
Right.
FFR introduced for that purpose only, sir. FFR main indication of FFR.
No, FFR was introduced where you are not 100% sure કે આ 90% બ્લોક છે 95% બ્લોક છે પણ આમાં ફ્લો દેખાય છે then FFR can give you an idea કે આ 0.8 છે કે 0.8 થી વધારે છે.
FFR નું meaning એટલે functionality check કરવાની છે. ભલે તમારું stenosis છે પણ obstruction નથી.
What I मतलब एक FFR की इंडिकेशन में एक था कि to differentiate intermediate coronary lesion. That's right.
बट कहाँ पे बेटा अगर आपका 70% ब्लॉक है
हाँ।
तो दुनिया का कौन सा FFR उसको लेस देन 0.8 देगा? Is it not possible?
तो
Just use your common sense here.
हाँ, sir.
See, I am not an international cardiologist,
Yes.
right? अगर if you have a plaque
हाँ।
which आपको visibly 60% लगता है,
हम्म।
40% आपकी नली खुली हुई है,
Yes.
उसमें FFR लेस देन 0.8 आने के चांसेस कितने हैं?
Chances are there, sir.
कितने? 1%, 0.5% या 90%?
10-20%.
10-20%?
Yes.
दिखाना मुझे कहाँ पे लिखा है?
Sir, I will show you study of FFR, sir.
या श्योर उसमें आप पहले देखना और उसमें कौन से ब्लॉक में FFR ज्यादा आपको हेल्प करता है।
Yes, मैं वो
It
study
must be more than 80-90% वाले ब्लॉक में वो
ये
help
FFR
करता
का
है।
एक डिटेल स्टडी एक बार मैं आपको मतलब
Exactly, right? अगर 70% में FFR की जरूरत पड़ती दोस्त तो वो तो हमें सोचने की जरूरत है तो फिर।
और सेकंड थिंग क्या है सर, मतलब अभी रिसेंट जो गाइडलाइंस है, स्टेनोसिस मोर देन 70%. If patient have the clinical picture of angina, then right state the patient without FFR. That was the indications. We don't do generally FFR for the severe or critical lesions, sir, like 90%, 95%. Sir.
वापस बोलिए क्या बोले?
For severe or critical lesions, we don't need FFR. We have to direct stent the patient, sir.
Of course.
Yes, sir.
उसमें तो FFR की नीड ही नहीं है।
Yes.
आप पहले कुछ 70% बोल रहे थे।
हाँ, तो 70 में जो आपने जो बोला वो मुझे एक बार डिटेल एक
हाँ,
करके
वो
आपको मैं
देखना।
I will get back to you, sir.
अगर 70% में FFR मैंडेटरी हो जाता है तो पेशेंट तो बेचारा ठीक है प्रिवेंटिव एस्पेक्ट से करना चाहिए बट आप FFR करोगे आप
There was a
IS
point of cost also, sir. You mentioned in this slide.
At that time there was also confusion that from which angle you had taken that radiograph.
Yes.
Sometimes it may look like it may be 70%, but actually it may not be 70%.
Yes.
तो वो तो IS OCD में क्लियर हो जाएगा
हाँ,
कि
वो
उसमें
उसमें
60 डिग्री
तो
देगा
we can calculate from IS. कोई FFR का एक बार डिटेल में कितने
बट जो
इंटरमीडिएट
दलाल सर ने बोला ना वो एकदम प्रैक्टिकल है यू कैन क्लियरली अवॉइड 1.8 लाख रूपी कैथेटर इन अ पेशेंट
ओके सर.
क्योंकि अगर हम कंक्लूड ये करते हैं कि ये तो साला वल्नरेबल प्लेट है तो उसको स्टेट का भी खर्चा तो आएगा ना तो आप टोटल मिलाओ जो बंदा जो
આઈવસ की થઈ જ જાય ને પેલું FFR મેજર થઈ જ જતું હશે ને
नहीं,
हां कैथेटर नाखવું પડે છે 1.8 लाख ની તો
different.
IS
IS is a pressure catheter only, sir.
अच्छा।
It take the distal or proximal pressure.
उससे नहीं हो सकता.
तो सपोज आज मैं चेस्ट पेन लेके आता हूँ
हाँ।
जिसमें क्वेश्चनेबल कार्डियक है
हाँ।
और ब्लॉक 70% आया
Yes।
और मैंने FFR चलो छोड़ दिया बट आईवस किया ओसीटी किया अनफॉर्चुनेटली वो थिन फाइब्रस वल्नरेबल
सब
प्लेट निकला और हमने स्टेट डालने का डिसीजन लिया तो मेरा कितना खर्चा हुआ टोटल बताओ
वो तो ऑफ कोर्स इससे कम ही होगा सर.
कितना
1.5 तो कम हो गया ना.
आईवस ओसीटी आपका कन्वेंशनल एंजियोग्राफी और आपका स्टेंटिंग और आपकी फी मिला के कितनी होती है 4 लाख
3.5 almost.
राइट
3.5.
सो क्वेश्चनेबल कोरोनरी के लिए अगर मैं कोई हॉस्पिटल में एडमिट होता हूँ 3.5 लाख देके निकलता हूँ जस्ट इमेजिन द प्रैक्टिकल सिचुएशन
हाँ सर.
और उसमें आप एफएफआर का कैथेटर डाल दो 5 लाख
अपना केस डिस्कस कर लो लास्ट में कर।
हाँ, So coming to the last case, this patient was randomized to OMT group. After 1 year, 7 months of follow-up, later patient developed chest pain, and here in the second image you can clearly see the progression of plaque with severe narrowing of the left LED artery, which was disease progression. So we
In
have
spite of giving
in
rosuvastatin for
spite of the patient was on OMT only, they categorized this patient from OMT. So they have to stay in proximal LED. This was the one worst outcome in OMT group, sir. And the same second patient they have mentioned, patient was a critical lesion in RCA and LED. Both were stented upfront in the primary angioplasty, and they have the moderate lesion in LCXR. So they analyzed the lesion. They have stented RCA and LED for primary cardiac lesion, and they kept non-culprit LCX randomized to OMT group. But this LCX has MLA was 2.8 and plaque burden was 81%. That is vulnerable plaque. But according to randomization, they randomized to OMT group. After 11 months of follow-up, the patient has repeat chest pain, and we can see the progression of this disease. So this was second worst outcome in the OMT group, and they stented this. So to treat or not to treat functionally insignificant vulnerable plaque, so this study concluded to treat the functional vulnerable.
એટલે IOS is most બધામાં FFR બી
FFR can be measured through CT also. There is a
Ah, sir, CTFFR new is there. So CTFFR is non-invasive FFR. We can make.
ના પણ એ તો આઈવાસ ને ઓસીટી કરવાનું હોય તો સીટી માં નાખવાનું તો કોઈ મતલબ
એ
નથી.
કેટલામાં પડે એટલે
I don't know.
કોસ્ટ
CTFFR का पता नहीं.
પણ ટ્રાયલ કરનારા કોસ્ટ તો જન્મ જ નથી લીધી એટલે એને નીચે લખી દીધું લિમિટેશન માં
लास्ट में कॉस्ट में डाल दिया सर, कॉस्ट इज नॉट.
તો સીટી એફએફઆર બી